Good day everyone. Our topic for today is a class of compounds known as Eicosanoids. Eicosa in Greek means 20. Later we'll find out why it was named this way. Eicosanoids are endogenous fatty acid autocoids. So remember, biochemistry could be divided in terms of macromolecules: protein, carbohydrates, lipids, and nucleic acids. So specifically, eicosanoids are all fatty acids. Why are they all fatty acids? Because they are all derivatives of arachidonic acid. Arachidonic acid is a 20-carbon fatty acid lipid located in the cell membranes. So arachidonic acid is located in the membrane, and when we need to use them, when we need to convert them into eicosanoids, we get from the cell membrane. Okay? So this is just the outline of the eicosanoids that we're going to tackle this meeting. Some are straight-chain derivatives, while some are cyclic. As you would see, straight-chain derivatives are known as leukotrienes, while cyclic derivatives are known as prostaglandins. However, some prostaglandins have special names. For example, prostacyclin is also known as PGI2. Also, thromboxane is another cyclic derivative. As you could see, leukotrienes and prostaglandins are named as this. B4, so there's a number and there's a letter. Later we'll see the structural basis for this naming system. But of course, I would like to remind you that structures won't come out in the exam. Focus on the stories of each of these compounds. Now, as for drugs, we actually have eicosanoid antagonists. So the drugs that we have mostly counteract the action of our endogenous eicosanoids. For example, we have leukotriene antagonists, such as these drugs for bronchial asthma or asthma. This includes Xylitol, Mentelocast, and Zafirlocast. In contrast, we also have prostaglandin antagonists, the most commonly known of which is the NSAIDs. However, corticosteroids also have activity against prostaglandins. Just to put this topic into perspective, eicosanoids are actually a part of a class of compounds known as autocoids. Autocoids, on the other hand, comes from two Greek words, Greek autos and akos, self-remedy. So, these compounds are important in modulating acute inflammation. So, some autocoids promote, while some control or regulate or inhibit inflammation. In your other classes, you're going to tackle different autocoids, specifically those that come from amino acids and polypeptides. But take note that for now, we're focusing on those derived from fatty acids, the so-called eicosanoids. So just for completion, let's look at the decarboxylated amino acids. Histamine and serotonin are examples of these. Other polypeptides include angiotensin, kinases, vasoactive intestinal peptide, and substance P. What's the structure of arachidonic acid? Arachidonic acid is also known as eicosa tetraenoic acid. As we have mentioned, eicosa means 20 because this structure is 20 carbon. Tetraenoic because en refers to the double bonds, while tetra means 4. So let's look at this structure. There are 4 double bonds. 1, 2, 3, and 4. And of course, this is a fatty acid because here we have a carboxylic acid moiety at this end. As we have mentioned, there are two major classes of eicosanoids, prostanoids and leukotrienes. Prostanoids could be divided further into prostaglandins and thromboxane. As I have mentioned, prostanoids have a cyclic structure, while leukotrienes have a linear structure. So the enzyme that synthesizes prostanoids is cyclooxygenase, while the enzyme that synthesizes leukotrienes is lipoxygenase. To better understand this, let's look at these figures. As I have mentioned, prostaglandins and thromboxanes are prostanoids, and look at their structure. They have this cyclic structure. Prostaglandins have a 5-member ring, while thromboxane has a 6-member ring. While for leukotrienes, you could see that there are still 4 double bonds, but it's completely linear. Aside from that, 3 of the double bonds are said to be conjugated. In other words, it's alternating single-double. So if you would review your chemistry, that means that their electrons are delocalized. Delocalized. So if you would recall, prostaglandins and leukotrienes are named with a letter and a subscript number. So what's the basis for that? Well, the basis for that is still structural. So for example, the letter refers to the specific ring structure. For example, if it's PGA, it has this ring structure. If it's PGD, it's this. If it's PGE, it's this. And so forth and so on, up to F, G, H, and I. As you could see, I as a more complex structure. It's not exactly 5-membered. While for subscript number, it indicates the number of double bonds present in the fatty acid chain. So let's look at it in this figure. For example, if it's PGE2, it has 2 double bonds here and here. If it's PGF2 alpha, it has 2 double bonds as well, here and here. PGI2 or prostacycline has 2 double bonds here and here. Thromboxane A2 has double bonds here, while leukotriene A4 has 4 double bonds. So what differentiates eicosanoids from other hormones? Eicosanoids are not stored. So they are synthesized and released on demand. So when the cell needs eicosanoids, they get it directly from the cell membrane. Aside from that, it's also rapidly degraded. Because of it, its action is mostly local, unlike hormones, which have to be synthesized from a central location and then distributed through the blood throughout the body. So its mode of distribution is what we call autocrine or paracrine. Auto means self. Para means nearby. So its action is specifically connected to its own self, to its own cell, or to nearby cells. So how does our cell get the arachidonic acid from the cell membrane? Let's try to recall the structure of membrane phospholipids. So if you look at this figure on the next slide, here, this is glycerol, and this is, the whole structure is a phosphatidyl inositol. This part here is inositol. There's a phosphate moiety here. So depending on the type of phospholipase, it could cleave this triacyl compound or diacyl compound. So arachidonic acid is located here usually. So phospholipase A2 cleaves this bond in order to liberate arachidonic acid. So this happens at times or at points of inflammation. Okay? So these polyunsaturated fatty acids, namely arachidonic acid, is freed from membrane phospholipids by the enzyme phospholipid A2 or phospholipase A2. So its activity is promoted by these factors: interleukin 1, which is a pro-inflammatory cytokine, angiotensin 2, bradykinin, thrombin, epinephrine, TGF-beta, and epidermal growth factor. It's regulated or controlled because, of course, inflammation doesn't have to happen uncontrollably. So there are some regulatory factors, and that the most important one that you have to learn today is annexin 1, also known as lipocortin. And this is the mechanism of action of corticosteroids. Corticosteroids promote the expression or the release of annexin 1, also known as lipocortin. Caspase 3 also promotes the release of annexin 1. Take note that the dietary sources of polyunsaturated fatty acids differ. So for example, in Western diet, it's rich in arachidonic acid, while a diet rich in cold water fish or plants, like that's in Mediterranean diet, or in the Philippines, those that proposed by Pinggang Pinoy, are rich in eicosa pentaenoic acid. So in terms of structure, what's the difference between them? Arachidonic acid has 4 carbon double bonds. So, the last double bond is located 6 carbons away from the end of the hydrocarbon chain. That's why it's called an omega-6 fatty acid. In contrast, eicosapentaenoic acid is more unsaturated because it has 5 double bonds. So the first double bond is located 3 carbons from the end of the hydrocarbon chain. That's why it's called an omega-3 fatty acid. So because of this, some sources have suggested that Western diet is actually more pro-inflammatory, while some have suggested that the Mediterranean diet is more anti-inflammatory. And their basis for saying that is the content, the fatty acid content of these diets. So what's the significance of that? Some say that it contributes to the formation of atherosclerotic cardiovascular disease, pro-inflammatory diets. Because remember, the formation of an atherosclerotic plaque is not just simple fat deposition. It's pro-inflammation. It's inflammation on top of fat deposition. How are these compounds synthesized? So as I have mentioned, omega-3 is generally good, right? While omega-6 is generally bad. So synthesis starts from either linoleic or linolenic acid. Both are 18 carbon compounds, but both are fatty acids, right? So for linoleic acid, it starts off with 2 double bonds located at the omega-6 position. While for gamma-linolenic acid, it gains another double bond. So tatlo na yung kanyang double bonds. It eventually becomes dihomogamma-linolenic acid, which is a 20 carbon compound. Then when an additional double bond is introduced, it becomes arachidonic acid for a total of 4 double bonds. So you can see, arachidonic acid is rich in red meat, so as well as in poultry and eggs. Linoleic acid is found in these oils, vegetable oils as well as flour oil. In contrast, omega-3 fatty acids are found in green leafy vegetables, flax and chia seeds, canola, walnut, and soybean oil. Specifically, we have eicosapentaenoic acid as well as docosahexaenoic acid. If you remember our lecture on lipid-lowering drugs, you would remember that some of these agents could be used to lower lipids. Eicosapentaenoic acid and docosahexaenoic acid are found in fish, specifically oily fish, also krill oil and algae oil. So right now, let's learn about the 3 starting molecules. So there are 3 starting molecules that I would like you to learn, and one of them contains 3 double bonds, one contains 4 double bonds, and one contains 5 double bonds. Let's start with the one that contains 4 double bonds, and that is arachidonic acid. Arachidonic acid, also known as 5-8-11-14 eicosatetraenoic acid. Take note that the locations of the double bonds are like this. So for the 4 double bond compound, it's 5-8-11-14. For the 5 double bond compound, it's 5-8-11-14-17. While for the 3 double bond compound, it's 8-11-14. Okay, so where do those numbers come from? So let's count here in the structure of arachidonic acid. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So it's just based on the location of the double bond, starting from the carboxylic acid moiety. Alright. Arachidonic acid is rich in Western diet, as I have mentioned, and is also most abundant. It's the starting molecule for the production of PG2s, specifically prostaglandin E2 and prostaglandin F2 alpha, generally pro-inflammatory. In contrast to the 2 series, prostaglandin 3 series comes from eicosapentaenoic acid, also known as EPA. Again, it comes mostly from fish oil. Okay? And take note that some of the 3 series have an opposite effect than the 2 series. So generally, they are anti-inflammatory. For example, Thromboxane B3, produced from eicosapentaenoic acid, was found to inhibit platelet aggregation. So it may protect actually from cardiac events such as myocardial infarction. And lastly, the 1 series comes from 8,11,14 eicosatrienoic acid, also known as dihomo gamma linolenic acid, also known as DGLA. So by the way, if you notice this notation, the first number corresponds to the number of carbons. Then there's a colon, and 3, the next number specifies the number of double bonds. In parentheses, and sometimes written as delta, then in superscript is the location of the double bonds, numbered starting from the carbonyl carbon. Okay. So let's look at this figure. This one is overwhelming at first, but it just shows you how prostanoids are derived from arachidonic acid. Okay, so let's trace it step by step. So arachidonic acid is acted upon by cyclooxygenase to become PGG2, and drugs that target cyclooxygenase are the COX inhibitors, aspirin, as well as the COX-CIBs. Specifically, aspirin and other NSAIDs are non-specific, while the COX-CIBs are selective COX-2 inhibitors. So from there, it gets acted upon in a second step by peroxidase to convert it to PGH2. PGH2 is the branch point because it gets converted to the other types of prostanoids. So for example, it could become thromboxane A2, or it could be PGE2, PGF2 alpha, PGD2, and PGI2. So if you're going to remember, just as a heuristic, just to help you remember this, take note that all of these are pro-inflammatory except prostacyclin, which is PGI2. Also, it's important to note that different prostanoids bind to different receptors, and it's important that for each receptor, you know their location. So for example, thromboxane A2 is pro-inflammatory and procoagulant. Take note, this is different from thromboxane B3, the anti-inflammatory one we mentioned earlier. So this is thromboxane A2. If you remember primary hemostasis, it's involved in that. So the general location is the platelet, right? Because it's involved in blood coagulation. Aside from that, it's also located in the kidney, in the smooth muscles of the blood vessels, as well as in macrophages. PGE2, on the other hand, is found in brain, kidney, vascular smooth muscle, and platelets. For PGF, it's important to know that's located in the uterus. So as you will see later on, it's going to have some significance in pregnancy. Remember, pregnancy is a general state of anti-inflammation or controlled inflammation. So if inflammation is stimulated during pregnancy, for example, if the mother has an infection, uterine infection, then it could trigger a premature delivery. Next, PGD2 is found in the mast cells, brain, and airway. And lastly, prostacyclin is found in endothelium, kidney, platelets, and brain. So we're done with prostanoids. Let's summarize the steps next of the synthesis of leukotrienes. So here in the pathway, I would like to emphasize this step, 5-lipoxygenase. During the synthesis of prostanoids, we have cyclooxygenases. For the synthesis of leukotrienes, we have 5-lipoxygenase. It is important to note this because this is the target of the class of drugs known as 5-lipoxygenase inhibitors. It includes Xileuton. Okay, so 5-lipoxygenase oxidizes carbon number 5. That's why oxygen is introduced here. From there, it gets acted upon by leukotriene C4 synthase, and it leads to the class of compounds known as cystenyl leukotrienes. It's important to learn about them because they are involved in asthma. Also, there's another class of anti-asthma medications known as cystenyl leukotriene 1 antagonists, and it includes zafirlukast and montelukast. So there are two drug classes here important. 5-lipoxygenase inhibitors, and cysteinoleucotriene antagonists. So what's the chemical nature of the prostanoid receptors? Take note, they are not ion channels, they are G-protein coupled receptors. So in terms of structure, it's a 7 transmembrane protein. 1, 2, 3, 4, 5, 6, 7, yes. So this is your membrane, and it passes through the membrane 7 times. So there are 5 different types: EP, DP, FP, IP, and TP. So they are the binding sites respectively of prostaglandin E, D, F, and I. TP is the receptor for thromboxane. There are 4 subtypes of EP and 2 subtypes of DP. So what happens after binding to the receptor? Let's trace the steps in these figures. Let's focus here on the lower half of the figure. If you'd remember, PGI2 is going to bind to which receptor? It's going to bind to the IP receptor. This is PGI, right? IP. So after binding, how will it transmit the signal inside the cell? So there needs to be a second messenger system. And because it's a G-protein coupled receptor, it could be of 3 types, either GS, GI, and GQ. For this example, we're looking at GS because that's the type of G-protein coupled receptor that IP receptor is. Okay? So GS is going to activate adenylyl cyclase. What adenylyl cyclase would do is it's going to convert ATP to cyclic AMP. Cyclic AMP, on the other hand, is going to activate protein kinase A. The effect of protein kinase A is to increase the levels of calcium, and it has an inhibitory effect on smooth muscle contraction by the myosin light chain kinase. That's why the overall effect of PGI2 is smooth muscle relaxation. Okay? A GI protein is going to have the opposite effect. While GQ works via a different mechanism, not via adenylyl cyclase but via phospholipase C. So this figure is slightly overwhelming, or this table is slightly overwhelming, but we just need to emphasize the important points. Again, PGE2 would bind to EP receptors. There are 4 subtypes of EP receptors, so their effect is not as clear-cut as the others. In contrast, PGF2 is going to bind to FP receptors, and important to note is that their location is in the uterus, so it's going to have an importance in pregnancy. So PGF2 alpha, when it binds to the FP receptors, is going to increase uterine tone. In contrast, PGI2, the only one which is anti-inflammatory, is going to decrease everything. Decrease vascular tone, decrease bronchial tone, decrease uterine tone, and also inhibit platelet aggregation. Its opposite in terms of action in the blood is thromboxane A2, while prostaglandin I2 or prostacyclin is anti-coagulation. Thromboxane A2 is pro-platelet aggregation. Again, recall our lectures on primary hemostasis. Okay? And lastly, the leukotrienes, generally pro-inflammatory. So look here, specifically leukotriene B4 is very good in calling upon leukocytes, a process called leukocyte chemotaxis. Just to reiterate, thromboxane A2 and prostacyclin have opposite effects. Thromboxane A2 promotes platelet aggregation. It's released only when a blood vessel is injured, in order to prevent blood loss, right? It makes sense. In contrast, prostacyclin is the one that inhibits platelet aggregation. It is released primarily from vascular endothelial cells to prevent platelet aggregation under normal condition. I have mentioned this point, but I would like to repeat it again. The fatty acid precursor is going to have an impact on its biologic activity. So we have mentioned the difference between omega-3 and omega-6. Omega-6 generally good, while generally bad, while omega-3 generally good. So the overall omega-3 to omega-6 ratio of your diet is important. We need to have more omega-3 in our diet compared to omega-6. Omega-3 is found in fish oil, For example, salmon, and here in the Philippines we have tinapa and dilis. Omega-6 is found in vegetable oils on the other hand. Okay? So compared to thromboxane A2, thromboxane A3 is synthesized from eicosapentaenoic acid, which is an omega-3 fatty acid found in fish oil. So it produces little platelet aggregation and vasoconstriction, and therefore it is protective against atherosclerotic cardiovascular disease. Okay, let's look now, before we proceed to the actual drug classes, let's look now into the different types of prostanoids, starting with PGI2 and PGE2. Okay, so PGI2 is also known as prostacyclin, right? It causes vasodilation, consistent with its anticoagulation or antiplatelet aggregation effect. Aside from that, it also maintains pulmonary blood flow, and among fetuses, it maintains the patency of ductus arteriosus, especially among newborns, until it is time for closure. So, some babies have what's called a life-saving patent ductus arteriosus. So, depending on their congenital anomaly, some of them rely on having an open ductus arteriosus. So, what we want to do is, we want to counteract the effect of we want to counteract the closure of the patent ductus arteriosus in order to preserve blood flow, right? Aside from that, PGE2 and PGI2 also have an effect on renal blood flow and glomerular filtration. They actually increase the excretion of sodium, and along with it, water goes. So overall, this has PGE2 and PGI2 have an antihypertensive effect. For PGE2 and PGF2 alpha, it's important to remember that they stimulate smooth muscle contraction, including smooth muscle in the uterus as well as smooth muscle in the GI tract. So for the uterus, they stimulate uterine contractions. That's going to have a relevance later on when we discuss the drugs that are analogs of PGE2 and PGF2 alpha. For example, in the case of abortion, those that increase GI motility can lead to can explain some of the adverse effects of these drugs. For example, diarrhea and cramping. Take note also that they have what we call a cytoprotective effect, meaning they stimulate the production of GI mucosa. So it's good for ulcers. In contrast, leukotrienes are more related to inflammation. Okay? They are produced actually by the inflammatory cells, specifically mast cells, basophils, eosinophils, macrophages, and neutrophils. Right? So generally, white blood cells. The particular leukotrienes, leukotriene C4 and D4, are called the main components of the slow-reacting substance of anaphylaxis. So now let's discuss the particular drug classes. You could have two drug classes, right? Those that simulate, or those that copy the activity of prostaglandins and prostanoids as well as leukotrienes, and those that counteract the activity of these compounds. Let's look first at the compounds that inhibit their activity. Okay? So for leukotriene inhibitors, we have two, and you have mentioned them already, and they are both used for asthma. While for prostanoids, we have NSAIDs and corticosteroids. As I have mentioned, NSAIDs inhibit cyclooxygenase, non-specifically. So, because for that reason, they are used to alleviate pain and inflammation. But because they are non-specific, they inhibit both COX-1 and COX-2. They also cause side effects such as gastric ulcers. So for this reason, COXIBs or selective COX-2 inhibitors were developed. For example, celecoxib. Right? Corticosteroids, on the other hand, block formation of all eicosanoids. How? By inhibiting phospholipase A2. Right? So it works more upstream. Because of this, corticosteroids are very powerful as anti-inflammatory, anti-allergic, and yes, even anti-neoplastic. So corticosteroids could be treated or could be seen as some form of chemotherapy. Example, for leukemias and lymphomas. So let's look now into leukotriene inhibitors. As I have mentioned, there are two, Zileuton and the leukotriene antagonists, such as montelukast, pranlukast, and zafirlukast. You're going to recognize cysteine leukotriene antagonists because they have lukast at the end of their name. Okay? So, we have two classes because they work on two different steps. Lipoxygenase inhibitors inhibit the step of the generation of leukotrienes from arachidonic acid. In contrast, leukotriene antagonists inhibit the binding of cysteine leukotrienes from cysteine leukotriene receptors. As you can see, most of their effects are respiratory in nature. Therefore, their usage is for bronchial asthma. So again, the step inhibited by NSAIDs are the step in which cyclooxygenase is involved. So there are two types of cyclooxygenases, COX-1 and COX-2. COX-1 is involved more on housekeeping functions. For example, maintaining the integrity of the gastric mucosa, right? While COX-2 is more involved in inflammation. So if you have a non-specific agent, for example, aspirin and other NSAIDs such as ibuprofen, one potential side effect that they could have is they could inhibit the formation, as well as affect the integrity of the mucosal barrier. Okay? That's why it could lead to gastric ulcers. So for this reason, COX-2s were invented. On a molecular level, how do NSAIDs work? What's important is their acetyl moiety. This is what they do. So in cyclooxygenase, they have the specific serine amino acid at a particular location. And serine contains a hydroxyl group. What the NSAID does is it transfers its acetyl group, it acetylates, in other words, the serine moiety of cyclooxygenase, and thereby inhibiting the action of cyclooxygenases. One way to remember this is to keep in mind that the other name for aspirin is actually acetyl salicylic acid. In contrast to this, corticosteroids have what we call a nuclear action. How does this work? So remember, corticosteroids come from cholesterol, right? So they are fat soluble. That's why they're not just floating in the blood. So they need to be carried in carrier molecules. So once it reaches its destination, the hormone gets internalized. So because it's lipophilic, it's able to traverse membranes easily. Okay? And once it binds to its receptor in the cytosol, it translocates. The complex translocates to the nucleus in order to affect the transcription of genes. In other words, it works down to a genetic level. Okay? That's why corticosteroids take some time to act. But because it works at the genetic level, its effect is also relatively long-lasting. Let's move on now to the class of drugs that copy the activity of these prostanoids. So we have drugs that are analogs of PGE1, PGE2, and PGI2. Let's start now with the class of drugs, with this kind of drugs that are analogs of PGE1. So the drug alprostadil is identical to the naturally occurring or our endogenous PGE1. So it's given nowadays for neonates, specifically those among neonates with a congenital heart disease in which we want to maintain the patency of the ductus arteriosus. It's given by continuous IV infusion. So formerly, it was given as an injectable into the cavernosa for erectile dysfunction in men. If you're curious about how this happens, you could just watch this YouTube video. Aside from being given as an injectable, it could be also administered as a pellet or cream, which is inserted into the meatus. However, there were some side adverse effects noted. There's noted penile pain, penile fibrosis, and what we call priapism. Priapism is a persistent erection, which doesn't go down on its own. So that's actually worrisome because it could lead to ischemia. Aside from that, flushing, diarrhea, headache, and fever were also noted. Because of that, nowadays, it has been generally superseded by oral drugs for erectile dysfunction. The oral drugs that have superseded them are called the PDE5 inhibitors. PDE5 stands for phosphodiesterase 5. So you may be familiar with the brand of some of these drugs. Sildenafil's brand name is Viagra, Tadalafil or Cialis, and Vardenafil brand name Levitra. Another usage of PGE1 analogs is as an abortifacient. For example, misoprostol. Misoprostol is not just an abortifacient, but it's also used for gastric and duodenal ulcers. Because remember, some of the prostaglandins have a cytoprotective effect on the gastric mucosa. However, here in the Philippines, it's illegal for use in pregnant women because it can stimulate uterine contractions and cause premature labor. And actually, if you use it together in combination with another drug, specifically mifepristone, other names of which include RU486 and mifeprex, is 95 to 97% effective, especially when given in the first 2 weeks of pregnancy. For PGE1 derivatives, let's move on now to PGE2 and PGF2 alpha derivatives. Okay, so their activity are related to the uterus and to the eyes. So let's first look at those that have effect on the uterus. So dinoprostone and carboprost have oxytocic activity. In other words, they mimic oxytocin in that they stimulate the contraction of the uterus. For example, dinoprostone is a naturally occurring prostaglandin E2, while carboprost is a synthetic derivative of PGF2 alpha. Dinoprostone could be given as a vaginal insert or gel. When applied to the vagina or cervix, it produces cervical ripening. In other words, it helps open up the cervix. So you need to do that in order such that the cervix becomes fully ripened or fully opened. And you need to do that before labor induction, because otherwise, if you stimulate contractions against a closed cervix, that's not going to be very good for the fetus. Okay? The suppository is used to evacuate uterine contents for whatever reason. For example, in the case that the fetus died in utero, you could give dinoprostone suppository to the mother. So some may have malignant, benign formations or tumors. For example, a benign hydatidiform mole. It could also be used for the termination of pregnancy in the second trimester. Carboprost, on the other hand, is given intramuscularly to control postpartum bleeding when other measures have failed. So, postpartum means after giving birth. So, some mothers have difficulty or fail to stop bleeding entirely. So, in order to control that, we could give carboprost intramuscularly. Aside from that, it could also be given as an abortifacient. Oh, by the way, how does stimulation of uterine contractions stop bleeding postpartum? It's because the uterus is covered by what's called muscular ligatures. So when the muscles contract strongly, in doing so, they also close the blood vessels. Latanoprost now is a PGF2 alpha analog. So this time, if we look at drugs that work on the uterus, this time we're looking at a class of drugs that work on the eyes. So it's the first prostaglandin drug indicated for open angle glaucoma treatment. So if you try to recall what's glaucoma, glaucoma is actually a narrowing of the angle of the eyes. So this leads to failure of drainage of the aqueous humor. Okay? So there are two types, angle closure glaucoma and open angle glaucoma. Specifically, latanoprost is useful in open angle glaucoma, in which there is not much of a narrowing, but there's just impeded humor outflow. So, what latanoprost does is, it promotes aqueous humor outflow by the uveoscleral pathway. Okay? Other options aside from latanoprost include bimatoprost and travoprost. So, you could recall their drug class because prost is in their name. Prost from prostanoid. So, they are given as eye drops. However, they have a strange side effect. They can cause a permanent color change in the eyes because they stimulate the production of melanin and melanocytes. Aside from that, they also promote the growth of eyelashes. So let's look at some of the figures here. So in figure A, we're looking at an increase in iris pigmentation after just 6 months of treatment. So for example, here, it's darker compared to this one. Figure B shows the lower eyelashes. So there was an increase in growth after 6 months of treatment. Figure C shows an increase in eyelid pigmentation. So it appears that they have darker circles here. And figure D lastly shows the increase in growth of eyelashes here in the upper eyelid. Lastly, for prostaglandin analogs, we have derivatives of prostacyclin. Esoprostenol has the exact same structure as prostacyclin. It is used to treat the condition called PAH or pulmonary arterial hypertension. Okay? So it dilates pulmonary blood vessels and increases pulmonary blood flow. It's given continuously via IV infusion. So the dose is titrated based on the clinical improvement of the patient. Also, we want to avoid adverse effects. What are these adverse effects? Adverse effects include flushing, tachycardia, hypotension, diarrhea, nausea, vomiting, as well as flu-like symptoms. We also have treprostinil. This time, it's not the naturally occurring structure. It has been modified to make it a stable analog. Its half-life is longer at around 2 to 4 hours. It's still given as a subcutaneous infusion via a self-inserted catheter. Okay, it helps in symptoms associated with physical activity in pulmonary arterial hypertension. So that's it. We're done with prostaglandins and leukotrienes, fatty acid derivatives of arachidonic acid. But just to complete our knowledge, let's focus on two compounds that are found in the body as well: endothelin and platelet activating factor. This is just to complete our discussion. Endothelin 1 is a peptide autocoid. It's unlike prostanoids and leukotrienes, right? So we're just discussing this because we've already started our discussion on the treatment of pulmonary hypertension. Endothelin 1 binds two receptors, ETA and ETB receptors. When it binds to ETA, it leads to vasoconstriction and cell proliferation. On the other hand, when it binds ETB, it causes vasodilation, anti-proliferation, and increased ET1 clearance. So their effects are quite opposite. Okay? So endothelin 1 physiologically counteracts the vasodilation caused by endothelin relaxing factor. So, in other words, it promotes hypertension because it vasoconstricts generally, right? So in pulmonary arterial hypertension, levels of this compound are elevated tenfold. Because of that, we want to target it using medication. In the next slide, we're going to look at the two medications used to antagonize the effects of endothelin 1. Our two endothelin 1 antagonists are bosentan and ambrisentan. We're going to remember them because they end in sentan. Bosentan brand name is Tracleer, right? Their difference is this: bosentan works on both ETA and ETB, while ambrisentan is more selective for ETA. Ambrisentan has 4,000-fold selectivity for ETA. Okay, so when you give someone bosentan, you need to monitor their liver enzymes. Aside from that, you have to take note that it's likely to cause major birth defects. So we have to counsel patients who are of reproductive age accordingly. Okay? And lastly, before we end, let's look at platelet activating factor. What is platelet activating factor? Platelet activating factor is another pro-inflammatory compound that comes from arachidonic acid. Okay? So these are its functions. It's a vasodilator, it's a platelet aggregator, low-inflammatory, and also contracts smooth muscles where? In the gastrointestinal tract, in the uterus, and in the lungs. Alright. One notable thing about platelet activating factor is that it's the most potent known ulcerogen. So it causes peptic ulcers. Aside from that, it's the most potent mediator of angiogenesis. So for example, people who smoke cigarettes, they have increased levels of platelet activating factor. So this is one of the reasons pointed out why cigarette smoking causes cancer. Okay? Alright, so these are just my references. Thank you everyone for listening. So if you have any questions, don't hesitate to send them to me. Thank you everyone.